How is dentistry akin to structural engineering? Can you walk us through that analogy?
Absolutely. When I teach, the basic principles of engineering apply to dentistry, and I like to show the parallels between famous engineering disasters and the same kind of disasters in the mouth. For example, one of the things that happens with periodontal bone loss is the bone disappears around the roots, and then eventually the bridgework that's attached to those roots collapses. That's very similar to what happened with the Schoharie Bridge in New York State, where the supports were sunk in sand and the sand washed away. It's called scour, and the bridge collapsed. That's exactly the same thing. What I see going on is a complete disregard of engineering principles.
Welcome to the Feriatecast. We'll bring you all things science, engineering, technology, and innovation. Today we are joined by Dr. Edward Feinberg, a distinguished dentist with over 40 years of practice and a unique legacy in restorative dentistry. Trained by his father, a pioneer in full mouth reconstruction, Dr. Feinberg represents a tradition documented by over 100,000 case photos spanning 70 years. Now the director of the ONWARD program, an online teaching organization, he is on a mission to educate dentists on evidence-based crown and bridgework techniques that prioritize longevity and tooth preservation over extraction. A nationally recognized lecturer, author, and reviewer for the Journal of Oral Implantology, Dr. Feinberg challenges modern dental norms by advocating for principles rooted in proving long-term success. So, Dr. Feinberg, welcome to the show.
Thank you very much. I'm happy to be here.
All right, sir. So let's start at the beginning. Your approach to dentistry is truly unique. Trained by a master in full mouth reconstruction with over 70 years of documented cases. So, what first made you realize that modern dentistry was moving away from proven principles and compelled you to dedicate yourself to preserving this knowledge?
Wow. I knew from the very beginning, even before I became a dentist, what was going on in my profession because I grew up in dentistry. As you mentioned, my dad was a pioneer of full mouth reconstruction and crown and bridge dentistry. I learned everything from him, and he came from dentistry's roots. He also had an amazing teacher. And what I really teach on my teaching website is basic principles. And what is happening is that these basic principles are routinely being violated without most dentists realizing that they're violating these basic principles. And that is why they are having so much difficulty with crown and bridge. So much so that they would rather extract perfectly good teeth that I could save in favor of putting implants in. And while implants are a wonderful restoration where they're indicated, they are not a panacea, and they will have a tremendous failure rate being used inappropriately. So that is what I am seeing now, an explosion of the overuse and inappropriate use of implants, when crown and bridge is most often a better choice. And what I mean by that is the one thing that most dentists don't realize is that crown and bridge is corrective because you can completely change the architecture with crown and bridge that you can't do with any other kind of restoration. You can bring the forces up close to the bone to minimize the forces on the supporting structures, which are the bone and the roots. And you can tie teeth together so that each tooth helps each other out rather than each tooth having to carry the load all by itself. And so with all these things that you're able to do with crown and bridge, if done properly, you can eliminate periodontal problems, and that's the end of it. So I have a lot of patients where which who had crown periodontal bone loss, and it was clear if that was left to continue, they were going to lose their teeth. And by changing the architecture with crown and bridge, that was the end of the bone loss, and they get to hold on to their teeth for most of their lives or maybe their entire life. And that is the purpose of dentistry, in my opinion. One of the things that I think is great about being a dentist is that I get to watch my patients come in year after year for their hygiene visits and watch the work that I did last in health. And I can show cases in the mouth 30 and 40 years that I did with x ray follow up. And this is an absolute rarity. When you go to the lectures in dentistry, or look at the articles, you rarely see follow up today. And all you get to see is how pretty the cases look when on the day of insertion. That means nothing to me. To me, the whole ball game is whether or not it holds up. And there are very definite basic principles that are involved in having a very high percentage of success with crown and bridge dentistry. And that the same is true of implants. And I can tell you some horror stories that I have seen with implants, which is very, very upsetting to me. I don't like seeing things like what I'm seeing. I don't really want to be known as a whistleblower because I love my profession and I'm very involved in my profession as a volunteer and trying to make things better. But I can't stand by silently when I have witnessed all these things and I know what kind of career I've had. So that's one of the reasons why I like to go on these podcasts, because I think the public should know what is going on in the profession and they have choices. So one of the main messages that I would like them to understand is if that they don't like what they heard, or one dentist says he can't save their teeth, maybe another one can. What I've seen is that a lot of patients are quick to get a second medical opinion, but they're not so quick to get a second dental opinion. They kind of do whatever their dentist says, which means that they think that we're all the same and we do all the same thing. And that is totally untrue. We are no different. We have all different levels of knowledge and skills. And so they should be aware of that, and they should find somebody who can help them in the way that they would like to be helped. That's my main message. I have no agenda. I have no, I'm not looking to make money in any way. I just want to further better care for the patients and also a better practice life for dentists.
Wow, that's truly inspiring, Dr. Feinberg. So, could you please tell us about the ONWARD program? So, what is it about and who is it really for?
Well, the ONWARD program is really a teaching website for dentists, but there's a lot of good information on there, and anyone who's interested in dentistry can go to the website. There's a there are 35 courses that I made in crown and bridge dentistry, and I continue to update and add courses to this site. But there's also a documents library with a lot of documents about different aspects of dentistry, including AI, because now I'm involved with the Dental AI Association. They made me the executive director. So I want to
Wow,
make sure that AI is applied properly to dentistry, because if we dentists don't get involved in how it's utilized, it's going to be a very terrible tool.
amazing, amazing. So, you have an incredible archive of over 100,000 case photos spanning decades. So, for our audience of engineers and data-driven professionals, I'd like to ask, what have these long-term results revealed about what actually makes dental work last?
Well, everything is basic principles. So it begins with tooth preparation. And our approach to tooth preparation is completely different than what is being taught. It's a three-dimensional approach that prepares the tooth, the gum, and the bone so that they relate properly in an ideal way. So the mouth is set up to receive the dentistry. That is how my dad and my dad's teacher did dentistry. Those techniques are not being taught. So when you look at x-rays of my finished cases, you could see that the margins of the crowns look like they're sitting on the bone. They're not, of course, but they're as close as possible to bring the forces up close to the bone as far as possible so that you minimize the stress on the tooth and the bone itself. And very often that is the end of periodontal problems because one of the causes of periodontal disease is poor architecture and poor force distribution on the teeth. And in a person who's susceptible to periodontal bone loss, when you have improper architecture and improper jaw relationships, you are going to have damage. And either the teeth wear or the bone goes. Those are the two things that go wrong in human beings. And the purpose of doing dentistry is to correct all those problems so that the patients can hold on to their teeth. So, one of the things that I don't like is watching new technology violate these basic principles. So first, what I mean by that is our approach to preparing teeth is completely different. What they are doing in dentistry is what's called butt joint restorations. And what I mean by that is when we prepare teeth, we put a ledge all around the teeth, and what most dentists are doing is making the restoration to the ledge. That's called a butt joint, and that's from carpentry. And the problem with butt joint is that bacteria are 2 to 10 microns, and those margins can never be sealed. So a lot of dentists have problems with recurrent decay and also poor retention, and they have problems with crowns falling out. And when you see teeth in a day, that is butt joint restorations, because the ceramic material will not allow thin sections that could go beyond the ledge. And there's also a material called zirconia, which came from nuclear power plants, in my opinion, belongs there, that everyone in the profession is using without any evidence for its efficacy whatsoever. It's a very, very hard metal. You could damage the teeth underneath trying to get one of these off. And they are all butt joint restorations that cannot be connected or soldered. So I think this is not a good material for dentistry, but it's being used because it's cheap and white, and nobody knows what they're getting. The best materials are precious metals. Any one of the precious alloys for porcelain is fine because they all handle basically the same way. And the best material ever devised for dentistry is gold, hands down. That's where dentistry came from. My dad's teacher only had gold and processed acrylic. And a good choice is gold and processed composite because composite materials are better than acrylic. So I made a lot of those cases on implants on people who were susceptible to porcelain breakage. But when I make crowns, my crowns are made on the model of the mason jar cover, which is the best known thing ever devised for food preservation. So I never get decay, almost never, under my crowns, and my crowns almost never fall out. In fact, I let all my patients wear the dentistry on a trial basis with rubber or Vaseline ointment to make sure everything is perfect before I cement it in permanently with permanent cement. And they do not fall out. And I also do this for teeth that have no tooth structure above the gum because my approach is completely different. All dentists are being trained that they have to hang their crowns off of whatever tooth structure is sticking up above the gum. And if they don't have enough tooth structure sticking up above the gum, they have to build it up with a post or build up or whatever to hang their crowns on. That is really not a very good practice. A lot of those fail. I don't care if there's anything sticking up above the gingiva. I care about what's below. So I'm trained to get a good grip on the root all the way down, which is not being taught, which came from dentistry's roots. And so I don't have these problems that everyone's having. And one of the reasons why there's such an explosion of implants and tooth extraction is because most dentists don't know how to save those teeth. And those are perfectly good teeth and no different, in my opinion. In fact, I don't even handle them differently. I still let the patients wear the crowns and bridges on a trial basis in the exact same way, whether they have tooth structure sticking up above the gum or not, because it doesn't matter what's sticking up above the gum. And that's the difference. And that's very sad because that came first. What I think happened is that the professors in the dental schools wanted to teach techniques to the students that they thought would be easier for them to learn. Because, in all fairness, they have a very limited amount of time and they have to teach them something so they can get out and do something. So I don't fault them for that. I fault them for not making the students aware that this is not the only way to do things nor the best way, and they unknowingly are violating the basic principles that allowed the dentists from the early years to have so much success. So a lot of the technology that violates the basic principles, like the machines that make the ceramic crowns in a day, really is not an advancement, because I really think that if we're going to advance as a profession, anything new that comes down the pike must be compared to the standard that came before. Otherwise, we are not advancing. There is some technology that is an advancement. One of the things that I think is an advancement is scanning and milling. And scanning is very accurate, but we don't have good intraoral scanners that can get below the gingiva. Although I heard that a company in Israel actually invented such a scanner, because I know somebody here in Arizona who has a camera that's a millimeter in size, and it goes under the gum, so he can view exactly what's under the gum, where all the calculus is, and doesn't have to flap open the case in order to clean everything out, which is amazing. And you could see clearly on the screen what's under there and make sure you get all of the calculus off. So they certainly should be able to make a scanner, if they have a camera that can do that. And I heard that it was invented, but it's not on the market yet. So at present, the only way that you can get an impression of the entire root surface below the gum is to use copper band impressions or aluminum shell impressions. And when I say that to my colleagues, they look at me like I have two heads. Oh, you're old fashioned, because the techniques that are being taught don't go under the gum far enough. That is the problem with the modern techniques. But if you have your models that you created with the copper bands or the aluminum shells, you can scan that in the computer and you could make milled restorations, and those fit. That's good technology. And there's some indications that milling may be superior to the traditional casting techniques that we've used since dentistry, the advent of modern dentistry in the beginning of the 20th century. So that's where I'm coming from in a nutshell. And I'm sort of like the lone voice in the wilderness, because I can't get too many people to listen to me. So when I started my career, people were focused on longevity and health. And what I see now is that people are focused on economics and workflow. And that is not right, in my opinion. I really cared about my patients and I wanted to do what was best for them. And I cared how long my cases lasted. I'm not implying that other people do not care, but I'm implying that they haven't been trained in the same way to look at things in the same way that I look at things. And so that concerns me, because I think that's important to being a doctor.
Wow. moving on, I'd like to talk about something slightly different. So, let's talk a bit about the comparison of dentistry to structural engineering. So, this question is kind of like of a particular interest to me, probably because I have a background in engineering. So, I like to ask, how is dentistry akin to structural engineering? Can you walk us through that analogy?
Absolutely. When I teach, the basic principles of engineering apply to dentistry, just as they would, like, say, if you were going to build a bridge across the river. And I like to show, when I give courses, the parallels between famous engineering disasters and the same kind of disasters in the mouth. For example, one of the things that happens with periodontal bone loss is the bone disappears around the roots, and then eventually the bridgework that's attached to those roots collapses. That's very similar to what happened with the Schoharie Bridge in New York State, where the supports were sunk in sand and the sand washed away. It's called scour, and the bridge collapsed. That's exactly the same thing. What I see going on is a complete disregard of engineering principles. So you have to look at the supporting structures and determine what you can do that doesn't overstress the supporting structures. If you have a strong mouth, you have teeth that are have long roots, roots that are curved. That's a strong mouth, because if the patient gets a little bone loss, they get away with it. But if a patient has short roots and roots that are conical, that's like the difference between putting a nail in the wall and a screw in the wall. That patient, a little bone loss, the effect is magnified and they're more likely to lose their teeth. And the same basic principles apply to implants. So what's commonly being done, which really I cannot believe, because all of the famous implant specialists and pioneers tell you not to overload these fixtures. In fact, there was a famous dentist who did a lot of study on biochemical stresses on implants, and he said that treatment of implants has to be centered around the management of biomechanical stress. That's true with natural teeth as well. Basic principles of engineering. But that's not what you see when you go to the lectures. They're doing a lot of these cases called all on four, where they pull all the teeth out and they put four implants in, and they usually flatten the ridges. And they put four implants in, but a lot of times they can't put the implants in long enough, and then they overloaded with big superstructures that not only replace the teeth, but the missing gum and bone as well. And sometimes they don't even allow the patient to clean around it. That's not where implants came from. The pioneer, the person who invented the osseointegrated implants, was Dr. Branemark, who I got to meet. And if you look in his book, he knew not to overload these things. And all of his teeth on his cases are narrower than natural teeth in order to put less stress on those fixtures. He knew that. And that was why he had a very high percentage of success. And when they first came to this country, implants were being done the way he said to do them, and they were only being done on people with no teeth. And typically they would put 4 or 5 implants in the front where the good bone is, and then they would cantilever the bicuspids off of that. And those cases lasted, and the patients were able to clean under them. So he had a very high percentage of success, but the success percentage is going to go in the toilet with what they're doing today. It may look pretty, but you can't do that and expect that to hold up. As simple as overloading a bridge, and it's not going to be able to withstand the forces. Like, the most famous bridge disaster is the Tacoma Narrows Bridge, where they didn't take into account the forces of the wind that were going to apply to this bridge. And they knew right away when they completed it that there was something wrong. And when they redid their calculations, they realized that when the wind speed reached 40 miles an hour, the whole thing was going in the river. And they captured this on film. The day was predicted for 40-mile-an-hour winds. And sure enough, the whole thing went in the river. So that is what happens in the mouth as well. In fact, there's another famous engineering disaster. Um, the Hyatt Regency in Kansas City, which is now a Sheraton. I got to stay in the Sheraton, um, but it has a very interesting history. When they were building the Hyatt Regency, the original plan called for one catwalk, which they attached to the fourth floor. And during the construction, they wanted to build another catwalk on the second floor. Can you do this? And the architect said, "Of course we can do this." So they hung the second floor catwalk from the fourth floor catwalk, and then they had this big party, and there were 100 people on these catwalks, like a New Year's Eve dance party, and they were looking at the dancing going on the main floor. And sure enough, the whole thing collapsed and 100 people got killed. And Hyatt Regency got rid of that hotel, and now it's a Sheraton with no catwalks. And that's exactly what happens in the mouth. You cannot overload these structures or you're going to have a failure. And that is routinely done today with these implant restorations that I'm watching in disbelief, because the main teachers tell you not to do this.
Wow, wow,
So
wow. That's
also, I'd like to mention one other thing too, because very often they stretch implants beyond what they were designed for. One of the problems with implant therapy is that in the posterior regions of the mouth, there's not enough bone to put good implants in. And on the upper, the bone is spongy, and very often the sinuses, which are a hollow cavity, um, are are empty, and they have to put bone grafts under the sinuses if they want to put implants in. And it doesn't always work, and sometimes they still can't sink the implants in deep enough. On the lower, you have the inferior alveolar nerve, and if you sink the implant into that nerve, the patient will be numb for the rest of their lives. So you can't do that. And so instead of stretching implants beyond what they are designed for, I made a lot of precision attachment partial dentures, which I wrote a textbook on, the double tilt precision attachment case. And it does not put stress on the abutment teeth. It works on the worst teeth you ever saw. So with implants, it's a no brainer. And I wrote a textbook on this that's available on Amazon. And it was invented in 1906. And nobody today knows anything about it. And in fact, they stopped making the attachments, which is nothing more than a simple male and female. And the retentive mechanism is the angle of how you take the removable in and out is tilted in two directions. And that's different from the pull of the muscles and gravity. So if a stress is applied to it, it can move slightly to relieve the stress, but it can't come out. Those cases last longer than any fixed bridgework case. I have all the evidence to prove that, and I can't get anybody to listen to me. And that is a great solution to the problem of trying to put implants in the posterior regions of the mouth. But the profession is so brainwashed into thinking that fixed bridgework is always better, that you can't get anywhere with educating people that this makes sense to put people through all this surgery. I'm also a reviewer for the Journal of Oral Implantology. So I had this article recently where they did all this fancy bone grafting on the lower above the nerve, and they still couldn't put the implants in deep enough. So, but they never show any follow-up. They say you get to see the x-ray, and like, I know that's not going to hold up, that the fixtures are overloaded, but you don't see any follow-up. And is this something that we should be doing? And I don't think so. And I think that the profession needs to take a good hard look at what's being done. And that's my message. And I can't get anyone to listen to me, which is very, very frustrating, because these are basic engineering principles, not to overload the foundation. And there are techniques that you can still restore the entire arch without overstressing either the teeth that are left or the implant. So I could show some miracles on the worst teeth you ever saw with these precision attachment cases, and
Mm.
um, and that and the patient got to hold on to their teeth. See, one of the things. See, my dad was a genius. Um, One of the things that they didn't have implants in his day, and he stuck his neck out to save teeth that today they probably wouldn't stick their neck out to save. And a lot of them worked. And he did it by minimizing the forces on these teeth so that they were able to be maintained. And a lot of them carry the load of these removable partial dentures. And because it's designed not to put stress on the teeth, they held up in spite of it. And that is amazing. I'm blown away by some of the things that I've not only seen but done. And I would like other people in my profession to be able to do this. And that's what I'm trying to do. I'm trying to teach them. I'm trying to reach them that there's a better way to do things.
Wow, that's truly inspiring. I mean, who would have thought thinking like an engineer can actually change one's approach to a complex dental restoration. Anyways, that was really insightful, even for me who is not really, in the dental profession. Yeah, I think I really learned a thing or two from that. So I like to ask, Dr. Edward, a central debate you highlight is saving natural teeth versus extracting them for implants. So, why is preserving the original biological structure often the superior solution?
Well, implants are not lifetime. I've had the cases where the implants lasted 20 years and that was it. And nobody knows why. And if you can hold on to your teeth as long as possible, I think implants should be a last resort, except in certain cases. Like, for example, if you were born with missing lateral incisors, that's a perfect place for implants. But otherwise, it should be a last resort and is being done as a first resort. So I'll tell you a story, which is terrible. This patient, I went to one of the courses, and there's a dentist here in Arizona. He's an endodontist, which is a root canal specialist. And he told this story at the course, and he showed the x-rays of this 20-year-old patient. She had a good mouth, really good long roots and good bone. And she had gone to a dentist who wasn't so good and didn't do the root canals properly, and they all had to be done over. And he wanted to help her so that she could afford it. I would have helped her too, but she wasn't my patient. I would have helped her. I would have helped her with the dentistry. But in the meantime, she went to someone else and he talked her into extracting all her teeth and putting one of these all on four cases that I talked about. And they flatten the ridges, and that's not going to hold up. She thinks that all her problems are going to be over and she never have to deal with it again. That is so not true. Her problems are first beginning, because when that fails, the ridges were flattened and she won't even be able to wear a denture. And I think that's awful. That is terrible. And nobody can say implants are lifetime. There's no such thing as lifetime. So when somebody asks me, how long is something going to last? How long any dentistry? I don't have a good answer because it depends on changes that occur. I can say I have a high percentage of success, but I can never say I have 100% because there are things that can cause bone loss that we don't know the answer to. There are systemic conditions like diabetes, heart disease, cancer that affect the bone in ways that we don't fully understand. But I can tell you, I can show you cases in the mouth that were designed according to the basic principles that I believe in that held up in spite of these diseases. Then you know you're doing something good. You would not expect that to happen. And then you know you're doing something good. And there are cases where the patients never needed implants because you corrected all the problems with good dentistry. And all basic engineering principles were followed to minimize the forces on the teeth, and the patient got to hold on to their teeth, and that was their end of their problem. And that's what my goal is. But but it depends. Dentistry is not lifetime, and I have patients with dentistry in them out 30 and 40 years, and they got away with it because the changes were minimal and gradual. And I have other patients where the changes happened, and after 10 or 15 years, the dentistry really should be replaced to compensate for the changes. That can be a very tough call as to when you should step in and do this because things are happening gradually and not all at once. But at a certain point, it should be done over to compensate for changes. Nobody knows why that happens in some patients and not others. So we're not gods. We can't predict what's going to happen. But with good dentistry, you could certainly hold on to your teeth far longer than you would otherwise. And then you could do implants. So now I have the ability to put 3 implants in the front where the good bone is and make a fixed bridge in the front and one of those removable precision attachment cases in for the back and stay away from all the bad anatomy in the back. And I don't have to put the patient through sinus lift surgery or any kind of grafting, all these things that are being done to patients. And so that is minimally invasive, and yet their entire arches are restored. And more should be done to look at this. So what could you do for a patient? What would you do if you had this? What would you want? It's not just the money that patients are concerned about. It's what you have to go through. And I'm very sensitive to that. When I try to figure out what's the best treatment for each patient, I would like to minimize what they have to go through. I want to make it as easy as possible so that, it's not an ordeal. And I spend a lot of time with temporary restorations because they're my blueprint. And I don't want them to have any trouble with temporaries falling out. I don't want them to have any trouble in between appointments if I can help it, and so that it's a pleasant experience, as pleasant as it could be. And that's what I have to offer. I can make that happen where most people are comfortable the entire time. And that means you have to pay very close attention to details. So I measure everything. I measure my temporary restorations. I measure my permanent ones. I don't want that different from my temporaries. I worked hard to get exactly what I want to correct all the things that are wrong in the temporaries right off the bat. So then, when it's very easy to make the permanent restorations exactly the way you designed the temporaries, and it's going to go in like a dream, and the patients are going to be comfortable right from the beginning. That's what my goal is, and that means you can't do one visit dentistry. You have to take your time, and you can't push people into major changes without giving the mouth a chance to adapt to them. And that's what I do with the temporaries. I spend a lot of time. I don't see anyone talking about that. They want to do things in a hurry, make a quick buck, put something in and make the money. And this is the other thing I'm going to say something about, because a lot of the young people are forced into that kind of thinking. It's not their fault. They sometimes get out of school, well, more often than not, with debts of $500,000. We didn't have that. And instead of focusing on how am I going to build my knowledge and skills, because what I got at dental school was rudimentary, they're forced to think about how am I going to pay these loans back? They'll never be any good that way, and they'll never give anything back or like the profession. And this is a bad thing that's happening right now that needs to be corrected. No one should start their career that way. It's not fair. And I'm involved with the Dental Association. And when the country settles down, I would like to make sure that dental education is subsidized so that they don't have to start their career that way. It's obviously very bad for dental care for the public. That's what I've seen over the course of my career, because we didn't get out of school with such debts. And I just don't think it's fair. It's not right.
Oh, wow, that's really, really insightful, Dr. Feinberg. So I like to ask, your life work has been about innovating within a tradition, using evidence to guide progress. So, in the context of medicine and dentistry. So tell us, what does innovation truly mean to you?
Well, as I mentioned, any innovation that comes down the pike must conform to basic principles. In other fields of dentistry, like endodontics or root canal therapy and orthodontics, they have made huge strides, very big advancements that have made that treatment much better and much higher percentage of success. But not my area, because the technology that's being invented, most of it violates the basic principles that allowed me and my dad's teacher to have so much success. So when you see this, you have to wonder, are we going backwards? Technology is a tool, not an end in itself. That's the thing that most people should be aware of. And now you can say that about AI. Like, for example, there's some good things about AI. One of the good things about AI is image interpretation, because there's a lot of differences of opinion and subjectivity when dentists are looking at radiographs. But the computer can see things that the human eyes can't see. Every pixel is related to the density of the object, and the computer could see that and also compare that with thousands of other x-rays. So that's a great tool, but it can never be the deciding factor as to what you should do for a patient. And we're seeing the advent of AI in a lot of other areas where the AI makes up stuff. They call it hallucinations, and it's not reliable. It makes up references that don't exist. Um, that needs to be that needs to be corrected. But because these companies are all they care about is making money and being first in the marketplace, they're not worried about safety, and that's worrisome. And so we have to keep our eyes open, because I'm most concerned now in dentistry that somebody's going to come and invent a treatment planning tool, and they're not going to include all the things that I just told you about the precision attachment case as an option. We have to program it. Dentists have to get together and program AI, and also instruct dentists where they can go to get the education they need to do some of these treatment options. And so this is a very not so simple. And if it's allowed to just peruse the internet on its own, it's going to be a terrible tool and come up with the wrong answers. And that's what I'm concerned about. That's why I'm involved with it. So technology itself can be a tremendous advancement. As I pointed out, milling is a tremendous advancement in a lot of ways. There's a company in Pittsburgh called the Strategy Milling Company, and they're at the forefront of milling precious metals. What they're doing is mind-boggling, and I think that's going to be a huge advancement in dentistry, because they can mill inlays and onlays and crowns and bridges instead of casting, and that gets around all of the problems with casting. That's what digital dentures is. It's milling instead of the heat and pressure method of making dentures, which had lots of problems. You almost never knew what you were going to get when you had a denture made in a laboratory. But milling is much more accurate and much more likely to have a good fit than with the old fashioned method. So that's a tremendous advancement as well. So there are a lot of good things, but the thing is to be aware of what the basic principles are, so that you can choose the technology that fits with those basic principles. And that's what I teach. Basic principles.
Fantastic. So, finally, Dr. Feinberg, for our listeners who want to learn more about your evidence-based approach, whether they are dental professionals or just curious patients, so where is the best place for them to find your courses, your books, and your extensive documentation on the ONWARD program?
Well, the ONWARD program is www.theonward, ONWARD program.com. And ONWARD stands for Online World Academy of Restorative Dentistry. So it's theonwardprogram.com. And I have two books on Amazon. One is a textbook on the precision attachment case that I described. And the other is a book of essays on different issues in dentistry. I have a monthly blog on my website, and I write about different issues involved in dentistry and my take on what's going on. So I'm thinking about maybe doing another book on of essays because now I know how to do it better. I'm also in the middle of writing another textbook, a textbook on crown and bridge that I hope will be adopted by the profession because I think it's really needed. And I hope that to turn attitudes around so that people, in my profession will be doing more what's really better for patients and not extracting so many teeth or condemning teeth that we know how to save, that have been done in history, cases like it. That there's, almost every kind of case on the worst teeth you ever saw. I think patients should have those choices, but they're not being given the choices because most dentists don't have the choices to offer them. So that's what I have to offer. And anyone who is interested can visit the website. The documents library is free. The introductory courses are all free, and the others are nominally expensive. And if I had dental students or somebody who was really interested, I wanted all the courses for free, they could contact me and I'd give them a special code and they could have all the courses for free. One problem that I see is that very few seem to be interested in learning. I want to be somebody's mentor in the way that my dad was a mentor for me, and I cannot find a single young dentist who wants a mentor. Think about that and what that means for the future, because I was very, very lucky. Nobody had what I had in dentistry, and I want to pass on what was given to me. That's very important. And I can only do it by the website and the books. I can't help anybody because they're not interested. And I'm baffled by that because I know when I started my career, people would have given their eye teeth to have somebody like me help them in their practice. I know that's true. So that if you think that's an advancement over all these years, it's not.
It has been a really insightful conversation, and I really enjoyed it, Dr. Feinberg. I'm really honored to have you on the show today.
Thank you. It's an honor to be on your show. I enjoy talking about dentistry, and you let me do all this talking.
All right.